Thank you. Thank you so much, Tom. Hang on a second, getting a message about the meeting being recorded. Well, thank you. As I mentioned, I'm the director of the HRSA Office of Women's Health. And again, just want to reiterate, it's my pleasure to be here today with our esteemed panel and the many partners and other stakeholders that are watching from around the country. And this community conversation is closely aligned with the mission of our agency, as Tom mentioned, which focuses on advancing health equity, improving access to care for underserved population, and supporting the health workforce. And within our agency, HRSA, my office, the Office of Women's Health, works to advance health and wellness for women across the lifespan. And we are committed to working together with our partners, both inside and Cancer Collaborative, which was an offshoot of the Cancer Moonshot, an interagency partnership to increase access to high quality cervical health in safety net settings of care. And this multi-year partnership will promote innovative approaches to cervical cancer prevention, screening, and treatment through engagement with providers, patients, other stakeholders, and through the development of educational resources for both providers and patients. President Biden and First Lady Dr. Jill Biden reignited the Cancer Moonshot this past February with new goals. First, to reduce the death rate from cancer by at least 50% over the next 25 years. And second, to improve the experience of patients and families living with and surviving cancer, ultimately driving us towards ending cancer as we know it today. HRSA-funded programs are critical partners in working to support these goals every day. The President and the First Lady also announced a call to action on cancer screening to jumpstart progress on the nearly 10 million screenings that were missed as a direct result of the COVID-19 pandemic, and help ensure that everyone in the United States equitably benefits from the tools that we now have to prevent, detect, and diagnose cancer. And as such, today's conversation will focus on strengthening screening in primary care and rural settings with the focus on health equity. And over the next hour, we will hear directly from HRSA grantees and stakeholders about the very important work that they are doing to promote cancer prevention and screening in communities all across the country. And we'll be sharing the information that we hear today directly with the White House Cancer Cabinet to inform and advance Cancer Moonshot priorities. And as Tom said, thank you to our colleagues from the White House Office of Science and Technology, HHS Secretary Becerra, for supporting today's Cancer Moonshot community conversation. And also like to take a moment to thank our Bureau of Primary Healthcare colleagues, Jeanette Dupuy, Amelia Khalil, and our Federal Office of Rural Health colleagues, Nigel Stinson, Saria Raffella, Michael Falcare, as well as Jane Segebrecht from my team for their support with today's important event. And with that, Tom and I are looking forward to hearing from our panel. Let's go ahead and start by having some brief introductions. I will go ahead and Dr. Andrilla, why don't we go ahead and start with you? Please come off mute and introduce yourself and your organization.
Hi, I'm Holly Andrella. I'm the Deputy Director of the WWAMI Rural Health Research Center, which is located in Seattle. And we have done we focus on the workforce, and we have done a number of studies looking at the stage at which patients with various types of cancer are diagnosed to sort of establish if that was contributing to the differential mortality rates that we see in rural and urban patients.
Thank you so much. Welcome. So happy to have you here. I'm just going to go to the right on my screen. Dr. Caudle.
I'm Mike Caudle. I'm Director of Women's Health at Cherokee Health Systems. It's a Tennessee statewide system with a number of rural sites. The positive screens are funneled down to us, our center in Knoxville and other sites. So we have a number of rural sites, and Tom said a lot. We've been collaborating with partners and so on to try to improve the results.
Wonderful. Thank you for joining us today. Dr. Amin, over to you.
Hi, good afternoon. Thanks, Nancy. My name is Rabi Amin. I'm the Southwest Georgia Clinical Liaison for the Georgia Colorectal Cancer Control Program. It's a group that consists of several different organizations in the state of Georgia. First, the Horizons, the South Georgia Cancer Coalition, then Albany Area Primary Healthcare, which is an FQHC, as well as another partner on the east, which is East Georgia Healthcare, Georgia Core, and Augusta University. And the Core is the Cancer and Oncology Educational Institute. And so our goal is to increase screening rates by implementing evidence-based interventions within our partner clinics and in rural sites across Georgia.
Thank you so much. Welcome. Dr. Callaghan.
Yeah, so I am Tim Callaghan. I am the Director of Evaluation for the Southwest Rural Health Research Center located at Texas A&M University. We do quite a bit of work in the area of cancer, sort of in two different areas. We do research focused on cancer, primarily funded by HRSA. Our center does quite a bit of work focused on chronic diseases, including cancer and other chronic diseases, looking at urban and rural comparisons and trying to understand why cancer outcomes, especially mortality, are different in rural and urban communities. We also have an outreach arm of our Rural Health Research Center, which does quite a bit of work focused on cancer screening. So we have large grants through the state of Texas, focusing on cancer screening related to lung cancer, cervical cancer, and colorectal cancer that we're all working on right now with community health workers, the College of Medicine, and the School of Public Health. So that's us.
Wonderful. Thank you. Welcome. Dr. Monroe.
Hi, just Casey. I'm not a doctor. My name is Casey Monroe. I am the Senior Director of Health Promotion and Disease Prevention at Adagio Health. We are located in Pittsburgh, Pennsylvania, and Adagio Health is a primarily women's health and wellness organization. My work focuses on our breast and cervical cancer screening programs, of which we offer in 62 counties of Western, Central, and Northeast Pennsylvania. The majority of our territory is fairly rural and deal with a lot of the issues that I know that we'll discuss today. My other hat I wear is the director of our tobacco prevention and control services in Western Pennsylvania, which obviously have a lot of correlation.
Fantastic. Thank you for joining us. And Dr. Ghosh.
Hello. So my name is Dr. Ghosh. I'm a gynecologist at East Boston Neighborhood Health Center. And the majority of my work with the clinic has been specifically with cervical cancer screening. And I've recently led a cervical cancer screening project in the middle of the pandemic. And we got some pretty interesting results. We made a lot of assumptions of how we were going to be able to improve cervical cancer screening. And some of the results were surprising. We've learned a lot. Some of our understanding is definitely much better than what it was prior to the pandemic. And I'm hoping to share. I'm not rural. I just realized I'm the only, like, I'm an urban clinic, but I really am excited to share what we've learned.
Fantastic. Thank you. We're looking forward to it. All right. I think we have introduced our wonderful panel from what I can see based on my screens here. So I'll go ahead and kick this off. Our first question for our panel is, in your view, what are the highest priority needs when it comes to supporting cancer screening in primary care, and how does your organization support this for the patients it serves? So please go ahead and raise your hand if you would like to speak. Excuse me, let me change my view. Okay, Dr. Ghosh, please get us started.
Yes, so I found what was a really high priority need was commitment. When I was hired originally as staff at our clinic, there was a cervical cancer screening problem. We knew we had overdue screenings, but the pandemic made it worse. Those numbers increased from 3,000 overdue to 7,000 overdue. And it was what led to us having a project and really starting to focus on change was the commitment from the leadership of our clinic. And that happened because I had the time to be able to evaluate our data and to understand the scope of our problem, to be able to present to them the numbers that were necessary for them to really understand, instead of having anecdotal discussions of, yeah, we really need to really improve our cervical cancer screening. I presented to our administrative and our clinical leadership to be able to state, these are our numbers. and specifically also saying what inaccuracies were in our numbers. So we really had an understanding of actually 20% of our overdue numbers weren't overdue. And that really allowed for a commitment and a project to be started and funding to be dedicated to the project. So I felt like that was the big first step that led to more than just, paying attention, but actually doing.
For that. Let's see, quite a few hands up. Great. No particular order, Dr. Monroe or Casey.
I'm going to come out of this discussion with my doctorate.
Right.
Thank you. So just to go back to who we are and what we do. So at Adagio Health, we oversee the Pennsylvania funded National Breast and Cervical Cancer Early Detection Program, of which we receive funds from the Pennsylvania Department of Health and CDC to operate. So part of this work is contracting and working with healthcare providers across the state. So we do not have any restrictions on who we partner with, though those who connect with us for our free screening projects typically fall in the women's health, OBGYN, some FQHCs. So one issue that we've identified as a team in this space is oftentimes the patients who we are seeing are uninsured or underinsured and make right at about the 250% or a federal poverty line or below. Sometimes their insurance status fluctuates. One year they may have insurance through an employer, another year they may not. And that has especially been true through the COVID pandemic. And one issue that we have identified is it's difficult as primary care providers may refer a patient to our program, either because they're due for their age or an abnormality that was identified or, strong family history. The tracking of when patients have had their last screening sometimes kind of falls through the cracks because of the different statuses in their insurance. So a way that we have been able to support this in our work is through patient navigation. On our team at Adagio Health, we have 4 patient navigators who are routinely looking at our clientele and folks who have used our services in the past to identify when their last screening was based on their age and their screening guideline recommendations, follow up with our patients to determine their current insurance status, and if we can help connect them to services again to ensure that they're connected to screening.
Great, thank you for that. Lots of hands up. Let's go over to Dr. Callaghan.
Yeah, so when we think about this issue here in Texas, we think about it in a few different ways. The first thing we're always thinking about is trying to remember that when we're thinking about rural health, rural is not a monolith. And that within rural, we need to be thinking about particularly vulnerable groups within rural communities. And a bigger point that we always are cognizant of is that we want to make sure that the screening we're providing, the care we're providing, is going to be culturally competent, and especially in the state of Texas, language specific. So the way our center tries to work on that is by making community health workers central to sort of everything we do. So community health workers in Promotoras in the state of Texas, and have them lead those promotion efforts to identify those who are really in need of our services, and working alongside the doctors to make sure that those patients get the services they need and serve as that bridge. So that is something we're always thinking about here in Texas.
Great, thank you. Dr. Amin.
Yeah, thank you. So a lot of things have already been brought up. I'm going to start with Dr. Ghosh, because I agree with her completely. The first thing is buy-in. Is once we get the buy-in with the community, even with from the clinics, then we're able to move forward. Our project, the GRCCP, the colorectal grant, is focused on EBIs, or the evidence-based interventions. And that kind of leads into what Casey was talking about. Is our number one thing that we found the most effective is patient navigation. So Horizons, the South Georgia Cancer Coalition, they overtake the patient navigation aspect of our colorectal program, and they also do some breast as well, some mammograms. And we found that that is the number one way to increase rates across the board, because the providers are doing their job 9 times out of 10. They're giving the FIT tests, or referring to colonoscopy, or whether it's referring for mammogram. But once they leave the clinic, the patients don't have as much they don't have the buy-in themselves, so they're not followed. So having the navigation aspect is critical. And also the other evidence-based interventions that we found that are effective are the provider reminders. So reminding the providers what they need to do, whether it's the daily basis or weekly basis or whatnot, and then provider assessment and feedback. So giving them their screening rates, as someone mentioned, the data is so that they know where they stand at a continual basis. That's something that we try to do monthly for our providers at Albany Area Primary Healthcare, so that they know where they stand and what they need to do to kind of hit the metrics that we're trying to hit. And then finally, patient reminders, which that's the hardest thing for us in rural health, is addressing those barriers to getting patients to come back to see us in a year and a day or whatever the timeline might be, because they may lose their phone numbers, they may have out-of-date addresses, their voicemails are full, XYZ. So those are the things that we see overall. And then the second major one after patient navigation is addressing, as I said, the barriers to care, which could be transportation, it could be insurance issues, as was spoken about already. It could be literacy, both healthcare and actual literacy issues, which we're finding that could be the case in some clinics. So, I mean, we've already talked about so much stuff, but I'm sure in the next hour, we're going to dive into some of these things.
Great, thank you so much. Dr. Caudle, over to you.
Yeah, clearly the strong points are cervical cancer screening, particularly with the new methods. It's disappointing that according to the ACS, American Cancer Society, 30% of women in this country still get pap smear only screening, when the HPV screening is much more sensitive and accurate. It takes 3 regular pap smears to equal 1 HPV test. So HPV is the real culprit, not just a regular pap smear. It's also disappointing that a lot of the pap smear only smears are done at FQHCs and at health departments. So we need to, it's good that people get something done, but we need to encourage people to use the most up-to-date and reliable methods for cancer screening. There are various reasons for this, such as doctors don't want to change, but the financial issue looms in the background too. But there's no reason why centers should have to pick an inferior test because of some cost of screening. I'm getting on my soapbox. So the other thing, of course, is HPV vaccines, which our pediatricians and we are rapidly doing. And of course, colon cancer screening, like Dr. Amin said. Our problem here is, for one thing, Tennessee did not take the Medicaid expansion. We have a real hard problem getting GI to see people with positive screens. And our people do come in and out of various providers, as the rest of people have expressed here. It's hard to track down the data on when their last screens were. We're kind of like dealing with a hodgepodge system. We've had some success in increasing the rate in minority populations of screening by partnering throughout the state with various community partners, such as the hospitals in Memphis, the health departments throughout the state, and various other entities.
Thank you for that. So many important issues here. Just want to take a moment and offer the floor to our panelists. Now that you've heard each other kind of share your initial answers to the question, a little bit more about your organizations, do you have any additional thoughts to add for us? Happy to pause for a moment if anyone would like to say anything more before we move to our next question. There's so much to say here. We don't want to miss a word. Dr. Ghosh, yes, please.
I just wanted to say quickly, and it may not be, I don't know how necessarily appropriate it is, but like in our project, the one thing that really helped things move forward was the ability to optimize IT. So, initially, 3 years ago, we didn't have IT staff that could really help us. We're on an electronic medical record, EPIC, at EBNHC. And for us, being able to have those consultants, even with EPIC, which to help us optimize The project that we were doing, our ability to gather data in our clinic was really important for us to be able to move forward and to be able to get the data we needed during our project and to be able to move forward with the outreach that we need with our patients.
Thank you. Dr. Amin.
Yeah, I actually I was thinking along the same lines, Dr. Ghosh. So that's one thing that we found, because in community health centers, the providers are bogged down like crazy. You know, they're given so many metrics to hit, all these KPIs that they have to, you know, numbers. It's an uphill battle for sure. And a lot of things that are discussed are the physician fatigue aspects of it. And so optimizing the EHR, we use ECW at AAPHC, and so just being able to kind of implemented order sets so that they can quickly and easily get a referral set done, and they don't have to click 18 different things to add a diagnosis and XYZ. So that goes a long way. Just I guess streamlining what we have and using the electronics to our advantage. But then also to Dr. Caudle's point that he mentioned, just yeah, the cost is always the biggest issue for all this, especially for colorectal and that aspect of colonoscopies. And not everyone can handle the cost, and that causes a barrier, especially for the uninsured, underinsured patients that we deal with. One thing that, and this could possibly be extrapolated to different cancers, but one thing that for the National Colorectal Roundtable developed a thing called the colonoscopy needs calculator. So what that does is if you input the information based on your health system, it can be something to present to a hospital system saying, this is the patient demographics, these are what we have. If by buying into or partnering with us, offering us some kind of deal or partnership, you'll save X amount dealing with the screening now versus 7 to 10 years later dealing with the cancer prevention or oncology, whatever intervention may be necessary at that time. So that's the huge thing that at least we're using for our partners to try to show them that this is a reason to buy into the community and help out. Again, it's whether they can do it or not, the GI offices are willing, that's another story, but something we can try.
Thank you. Thank you. Dr. Caudle.
I've seen some real tragedies in my time here, 11 years, particularly from rural areas where patients came in with advanced cervical cancer, including deaths. And the reasons why they weren't screened was we had no insurance. Well, in Tennessee, everybody can get on what's called the breast and cervical program. It's an offshoot of Medicaid. So it's very sad, and some of them were quite young. But we need some kind of information campaign. I see these things on TV about not smoking, with people that have had radical necks. People need to understand they can get screened, and they don't know that in the rural areas, or even in Knoxville sometimes.
Go ahead, Dr. Amin. Thank you.
Yeah, I wholeheartedly agree. I think the overall question right now is what's the highest priority? I think it's education. I think it's getting, and although we're in the business, so we see all the campaigns and everything, but I don't think outside of our bubble sometimes it spreads far enough. So I think the education is the highest priority, not even for patients 100%, but also for providers, to show them, for instance, the HPV testing rather than just the pap smear, because that's all that is really done here at our community health centers. They don't go the extra step. So yeah, 100%. That's kind of what we need to do.
Great, thank you. Go ahead, Casey, and then Dr. Ghosh.
I would support 100% what my colleagues are saying about education. I would just add to that, for any and all of the funders who are on the call, that oftentimes it's not the most funded work, as it's not always seen as measurable and quantifiable. So to keep that in mind, that for those of us who are doing that education work, of which Adagio Health does a ton of, we need to be able to put the dollars behind that to support that work.
Thank you for that. I think, did I miss a hand? I thought there
I just quickly wanted to say something that we learned about education on sort of a real ground level. And, in doing this project, we outreached to approximately 1,700 patients. And this was done with a small team of medical assistants and me, and just basically calling people. I mean, very sort of basic, and also, leaving messages, et cetera. And one thing that was interesting is understanding the percentage of patients that, not 21-year-olds, but 54-year-olds that didn't understand that they needed a pap smear. But also once we educated them, not in an in-depth level, but on a phone level, that, you still need this screening. And the whole point of our project was actually, or 50% of our project was trying to have patients come in for pap smears by having dedicated pap clinics, both within like regular working hours and extra clinical sessions, to be able to have women come in at night or on weekends to be able to help them. 40% of our patients still didn't show up. So we know that even our outreach that was so intense, even though 60% of women did show up, of those who made appointments, a lot of women still didn't show up with sort of the hands that were held to do that. So even more work. I mean, for us, our next steps are definitely more work in the community and using our community health workers and to be able to increase awareness for all of this. But I mean, I think I was a bit naive that, even with the education that we were giving on the phone, that, still patients making an appointment and coming in for that appointment there's still barriers.
Thank you for that. I don't see any more hands regarding that topic. So why don't we, Tom, over to you for our next question.
And I think this builds on some of the discussion that's already taken place, but I think this will certainly bring Holly back into the discussion, and that is, what are the primary barriers that you all are seeing to effective cancer care in rural areas? And then, are you aware of any organizations, or has your particular organization identified solutions that have been successful and helpful in that regard? Not to set you up, Holly, but I just thought I would.
Yeah, and that's fine. I think that one of the things that is a hard problem to solve, though I think getting easier with telehealth, is the workforce. The percentage of rural counties that do not have the right providers to treat patients is huge. And, we've seen then big differences in the rate of the stage of diagnosis, for example, by different socioeconomic status, by different racial groups. And so if the people aren't there where they are, the distance that they have to travel is so much farther. That's a big economic impact, not only just in the cost of traveling, but think about being gone from your home, your work, and so forth. So I do think that the workforce is a huge issue for all kinds of healthcare for rural populations, and cancer is one of those things.
Yeah, I'm glad you brought up telehealth. And so let's go to Tim, and then we'll go to Casey.
Yeah, I think Holly is absolutely right that the provider issue is real and needs to be thought about. But in addition to that, I think there's some other barriers in rural communities. One of the obvious ones, of course, is access to care, right? Especially in more red states with large uninsured populations. I mean, Texas alone is over 5 million uninsured Texans, and that doesn't even necessarily take into account the undocumented immigrants also living in the state who have limited access to care. So if we're thinking about a holistic view on screening and treatment, insurance is going to be a primary barrier to individuals seeking out those services. But that's not the only barrier. In rural communities, you also have to be worried about transportation, right? As we've had, well over 100 rural hospitals close over the past decade, providers tend to pack up and leave when those hospitals close. On top of that, which means people are traveling further and further to the care they need, which is increasing the travel burden for people in rural communities to get those cancer screenings that they might need. And then, two other things that stand out to me. One is, we might not even be thinking about this, but for some areas of rural communities, time off of work is a real concern, especially if you're working in certain agricultural sectors. Getting to a cancer screening during business hours can be a huge challenge. And then lastly, I think we can't ignore that, especially in some vulnerable minority communities, there are real concerns about trust in healthcare institutions. And I think all of those are sort of a potent cocktail that sort of limits the access that some individuals have to the care that they might need, especially preventive care.
It's a great point, Tim. I guess it could also lead us to more discussion of community health workers. Why don't we go to Casey?
Thanks. I echo what both Holly and Tim have shared. And rather than talk about barriers, I want to share a little bit about what we're doing at Adagio Health to help remove those barriers. About almost 2 years ago, we received funding as an organization from the Office of Population Affairs. We're also a Title X provider in Western PA, and we were able to purchase a mobile unit. So Adagio Health has been in business for over 50 years, and we've been in communities in Western Pennsylvania for that long. So we have really sunk our roots into these rural communities that we serve. We're a trusted and known healthcare provider. So the funds provided through Title X to purchase this mobile unit to kind of reach further into rural Pennsylvania, to partner with YMCAs, to partner with smaller employers who are not able to offer their employees health insurance, to do a pop-up mobile event has been really successful for Adagio Health and our title world, but it has also helped us to complement our cervical and breast cancer screening programs. So while our mobile unit is there offering title services, we're also offering breast and cervical cancer screenings as well. So a lot of those factors kind of tie together for us of how we're trying to remove barriers for patients in our rural communities.
I'm glad you brought up the mobile health option. I think that's incredibly important in this work too. So, Dr. Amin.
Yep. So yes, Casey, I was going to mention that the AAPHC also started a mobile thing, but she mentioned it, so I won't do that. But one thing that I can add to some of the barriers, similar barriers that we're facing, again, access to care, insurance, transportation, cost, everything. One thing that we found that helped the most for our population is the navigation. Again, that navigation to screening has helped tremendously. One, for ease and education for the patient. They're not as intimidated to speaking with the navigators, and they help basically handhold throughout the whole process and get it done. But they also address and help fix the barriers. So for instance, through our program, we're able to offer gas cards for instance, to patients to get to clinics or to the GI office if need be. And then prep and things like that, education on how to do that prep, where the providers might be bogged down, the offices can't really spend that much time. That's helped fill that gap there. And then just in general, for, I guess, trust of the whole process. They trust these navigators and like I said, if someone bothers you for a whole month to try to get something done, you're more likely to do it than just saying yes to your physician and then leaving the office.
Great points. Okay, Nancy, why don't we go back to you for the third question?
Thanks, Tom. Okay, our third question is, what recommendations might you have to support patient engagement in cancer screening? I know we've heard a few of those already. What might you like to share with us about that, patient engagement in cancer screening? Yes, Dr. Caudle. I think you might be on. Oh, there you are.
We need more providers of color. We're not getting anywhere with this idea very fast. But there is a level of distrust among populations when they look at somebody that looks like me. We found even nurses of color and MAs of color help. We have to do something to try to get the providers of color out. I know, for example, in the state of Georgia, they formed a network of African-American physicians to try to promote this. I'm getting desperate. I think it's time to go into schools and talk to children in elementary school and encourage them to become doctors, not just nurses. The little girls can be doctors or some other, I'm not disparaging the other occupations, but we are a long way from getting anywhere. The number of African Americans and Hispanics and other people of color in medical schools is not going up very much.
So important. Thank you for raising that critical workforce issue. Over to Casey.
Another thing I want to add, so I mentioned that Adagio Health has been in business for over 50 years now. And one of the things that is really important to our work is that we're actually serving generations of women. So we are currently working with the grandmothers, mothers, and granddaughters, multi-generational multi-generation of patients. And one thing that I know that we strive to do in our practices and strive to share with our partners across the state is to talk about the importance early on. So for grandmothers to be talking to their daughters, and mothers to be talking to their daughters, and about family history, about lifestyle factors, and to support that through family has been really important in our work. And I think that you can't underestimate the importance of kind of that familial tie, especially between women.
Fantastic. Working through all those different generations as a trusted messenger. Dr. Callaghan, over to you.
Yeah, and I think building off of what we've already heard, I think that the most important thing you can do to sort of build patient engagement with cancer screening is to make sure that you are trying to build trust, right? Cultural competence and building trust are vital to trying to make sure, especially with underrepresented groups, that they're getting the screening and treatments that they might need. There's certainly lots of approaches you could take to do that. The way our center does that here is by relying on community health workers and promotorists to lead the charge, right? By having leaders from within communities encouraging others within their communities to participate, you're helping to sort of bridge that gap of trust that might exist and make sure people have someone encouraging them that they trust to seek out the care that they need. So we tend to rely on that community health worker model. It's certainly not the only model, but we find it to be quite effective ourselves.
Excellent points. Thank you so much. Dr. Amin, would like to add something? Oh, I think you're on mute.
Sorry, everything kind of echoes a bit of what we're talking about. It all ties together for sure. Like Dr. Caudle mentioned, just having people of color does help, once they, especially, I mean, again, I know I kind of beating this to death, but the navigation process, having someone in the community that understands what you're going through, the barriers you might reach, but also, I mean, the providers, 100%, we need more diversity, more equality, like, someone that they can trust. But also just staff in general. I'm noticing a lot of FQHCs, we're having a lot of turnover issues just in general, a lot of MAs, staffing issues across the board, and not having a cohesive, base for the patient to go to is hard, because when you have turnover like that, there's no standard operating procedure, then there's chaos within the clinic and then chaos outside of the clinic. So that's something, I mean, there's no easy answer to that. I don't have a solution, but it's something that needs to be discussed probably, for the ongoing overall goals.
Right, really helpful. Thank you. Dr. Ghosh, did I miss your hand? Did you?
I sort of
want
raised
to
it and put it down because I didn't
Oh,
want to
okay.
necessarily be repetitive, but the only other thing that I wanted to add in patient engagement is sort of also obtaining an understanding of lack of engagement. So when patients are with you, like surveying patients, like again, like very basic things to be able to ask patients in their native languages, et cetera, about, why don't they want to get this screening done, and sort of, to be able to do that with community health workers is great. We do have some community health workers at our FQHC, but it's not like our main way to outreach to patients. That's with, our MA staff, et cetera. So I did get a greater understanding of patient needs through just simple surveys to be able to understand, why they don't want to get this done. And again, that's piggybacking on trust and cultural competency and all of that. But just sometimes numbers are very interesting for organizations to understand what's going on with their community, even though we all have a feeling that A, B, and C is going on, but to be able to see it sometimes on paper and with statistics, it helps.
Absolutely, that data is important. Common theme we're hearing today. Great. Any other thoughts to any of the things that the panelists have said? Any additional opportunity for discussion before we move on? Okay, great. I think, Tom, we're back over to you for our next question.
Yeah, I think we've hit on some of this, but it'd be interesting to take a little bit deeper dive and talk a little bit more about how you see this playing out in terms of health equity. we've talked about rural urban gaps, but as jarring as those are, I think they get really troubling when we look into racial and ethnic gaps and some of the institutional factors that are at work there. So I'd be curious from the panel how they see, what they see as some of the barriers in terms of achieving health equity in cancer prevention. We have Casey.
Yeah, this was already mentioned, but I think it warrants being repeated again. Workforce diversity, certainly in the clinical staff, it is challenging from what we hear from patients to open up and trust providers that don't look like them, also that don't speak like them or can't speak to them. So I would definitely emphasize that access to translation, especially in the rural areas. We have some challenges in Pennsylvania for sure, where there's not the ability to communicate with providers. The one thing that I also want to add that we see in our work with breast and cervical cancer screenings, and I'm sure you all do as well, but insurance can be tricky, and it's tough to navigate, it's tough to understand. It can land folks in a disaster, a financial disaster, when they don't even know what they're taking action to do. So it's a pie in the sky hope and dream, but if we could perhaps simplify some of these insurance issues, I think it would go a long way for folks to continue to engage in the continuity of care with regard to cancer screening, for sure.
Yeah, it's a great point. Financial literacy is linked to health literacy, and certainly in this condition. Okay, any other thoughts on health equity concerns from the panel? Dr. Callaghan.
Yeah, this is more of a research one as opposed to a screening or treatment one, but I think it's equally important, which is we're increasingly starting to think about not just rural and urban and not just racial disparities, but sort of the intersection of the two. And I think there is a growing need to have that research looking at that intersectionality, because you might see some small variations between urban and rural areas, but once you really dive down into data and look at it, those disparities can grow quite a bit larger. And we have a lot less research looking at, for example, race and rurality together as opposed to looking at each separately. And I think there needs to be a lot more work that's looking into that, because what little work we do have in those areas demonstrates that's where the biggest problems are. So I think there needs to be a lot more that's done there.
Yeah, we certainly talked about that a lot, and the limited sample sizes, and sometimes that precluding real analysis of the data from a rural, urban, and sub-rural perspective. Dr. Andrea.
The other thing I was gonna also mention that some of the interactions of being two different of these disparity groups does sort of have a extra effect, but also the thing that I think we need to pay attention to is that there's huge regional variation within the country. And so what's going to work in one place is not necessarily what's going to work in another place. And the problems that they are experiencing are really different. So I think this is going to have to be a tailored approach. There is a lot of data to suggest, the insurance issue, and there's lots of data to look at the racial differences. And there is a ton of data also to look at the geographic variation within our country. And it shouldn't matter where you are in the United States, whether or not you get the correct definitive cancer treatment, but in fact it does. So I think that's another thing we're going to want to keep in mind.
It's a great point, really is. Dr. Caudle?
I agree completely with that. And American Cancer Society is studying the issue of the pap smears, and you see this huge variation across this country when you consider New Mexico versus Tennessee. There also are some newer things that are being researched, such as self-collection of HPV tests. Somebody mentioned this, the technology is going to continue to advance. Most of this screening is always going to be done by primary care providers, and we need a better system for educating them. Also for consultation. I know in Massachusetts, they've developed a system for child psychiatry where you can get access into a consultant. We need to promulgate some stuff like this, because people are not going to know what to do outside of our system when they get a positive screen. In our system, they consult me or somebody like me and we get them in. But it's one thing to do a test, it's another thing to figure out what to do when you get one.
Good point. Dr. Amin? You're still, I think you're on mute.
Sorry, I keep forgetting. Well, just to add on, education, I think, is still a key aspect there, because if you ask a random patient of in the rural community or person, they automatically have a negative connotation to clinics, to doctors, to the cost of healthcare, to what's going to happen. And so that, I mean, again, like as Casey said, the pie in the sky, like if we're doing a moonshot, if we're trying to reach for the stars here, like changing the perception of medicine in this country, and just who it's for, who's able to afford it, who's able to get it, and what it is. It's just, it needs to have a shift in some way. Again, it's no easy answer, it's no small task, but that's kind of what it will take. Because if you ask the patients that we're trying to target in these areas, they don't trust the system, they don't trust the providers, as we discussed already, and they don't see themselves as the people that we're trying to get care for. And so that is one of the biggest hurdles that, you know, we'll have to figure out in this for this program to work eventually.
I think all of you raise really important points, and I think it brings out, if you don't mind me just pointing this out again, the notice of funding opportunity that came up today that HRSA released for the health centers, to create those sort of partnerships between cancer centers and primary care folks that people really trust. I think it's going to be an important step in sort of addressing a number of the factors you've raised today. So we'll look forward to seeing how that plays out. With that, Nancy, I'll send it back to you for the next question.
Well, thank you for that perfect lead in, Tom. In addition to funding, what additional resources do you think are needed to improve cancer screenings and also health equity in cancer screening? Yes, Dr. Caudle.
Politically naive, but when you think about the fact that one way or another, the federal government or governments pay for the majority of healthcare, whether it's Medicaid, Medicare, the FQHCs, the health departments, but still I hear things like, oh, these labs are too powerful, or money drives everything. Well, somebody needs to get after these MCOs, you know, and in our state, the Medicaid is run by various MCOs. They need to insist on quality work, you know, adequate screens for these populations. It's just a hodgepodge medical system that we're trying to deal with, but it's time for somebody to get serious, you know, when ultimately, one way or another, it looks to me like the government is paying for a lot of this stuff.
Thank you for that. Casey.
This may be a Pennsylvania issue, though I'm sure it's not, as it's growing across the nation. We are limited to so our health insurance here is tied to a specific healthcare provider, and it limits the access and the quality of care that folks have access to. It has become political and obviously a financial war. So we are seeing in our area that folks are losing quality to health, quality to care based on their type of insurance, which is becoming more and more troublesome.
Okay. Thank you for that. A really important point. Other feedback on what additional resources might be necessary? Yes, Dr. Ghosh.
I mean, one thing, what I just mentioned about, you know, we don't have a ton of community health workers, and we actually, you know, a lot of our cancer screening work is done through our quality improvement teams, to be able to improve that outreach and dedication to to understanding what's going on with our patients with cancer screening. You know, we were, one of the grants that I think is it's going to be a game changer for us, is we were able to get 20 AmeriCorps members. So young people that you know, are spending a year of their lives, you know, basically volunteering their time, etc. And we able to get that grant to be able to have 20 people coming into our clinic to do things that we need to do. And cancer is a priority, you know, cancer screening is a priority for us. So being able to have somebody for cervical cancer screening, and, you know, it's, you know, to be able to have the appropriate people. We're always talking about the teams that are around the work, and being able to find those teams. It's difficult. And I'll be honest with you, before hearing that we were getting this grant, I really didn't know much about AmeriCorps, et cetera. But in understanding what they're going to be able to do for us, I thought that adding to our workforce in this way is going to be really great and really help with the cause.
That's wonderful. Thank you so much for that. And I'm seeing, unfortunately, we're getting to the top of the hour already. We know this conversation was just a start, and there's so much rich information that was shared. I just want to touch on a couple of themes that I heard coming forth through the discussion. We heard about the importance of data, using data, some of the challenges with data, some of the successes in using data, in program management, both with patients and within organizations. A number of important workforce issues were raised, in particular, the great need for addressing diversity within the healthcare workforce, the importance of this across all disciplines, including highlighting the role that patient navigators can play and should play in helping the patients through the healthcare system. Cultural competency, of course, including linguistic access and competency, and all of that feeding into the concept of trust, building trust with the individual patient, with the family, with the community at large, and how we can better work together to help change the perception of that patients may hold of the medical system in their community and across the nation. Also, education, the importance of education and outreach, both to patients and also to providers about screening and the need and importance of screening. And of course, last but not least, payment issues, insurance issues, financial literacy, and the way that those issues can impact access to care. So those are just some of the top line highlights that I pulled away for this important discussion. We will be summarizing all of the feedback, as I mentioned in my opening remarks, feeding your comments back up to the White House Cancer Cabinet again, so that we can take action on the goals of the Cancer Moonshot. And Tom, I want to pass it over to you for any closing remarks that you might have for our wonderful group of panelists and participants today.
Just thank you. I've learned a ton just hearing you all and watching you react to each other, and some interesting models some of you have underway, but also you know, just a real understanding of the challenges out there, but you're all solution focused too, and that's really rewarding to hear. So just thank you for taking the time to be with us today.
Thank you.
Thank you so much, everyone. Thank you again, and have a great rest of your day.
Thank you very much.
Thank you for having us.
Thank you.